All right. Well, good morning. Dave Steffens, and chair of the Department of Psychiatry at UConn. A little known fact for when people go into psychiatry, when they go into actually academic psychiatry, they hand you a little chip that you can put on your shoulder, which helps you be sort of figure out whether you really are being picked on or not. And I will say that I felt a little picked on this morning. So I would say that there is, but rather than just dwelling on my own stuff, I thought that that I would say that there is cause for hope. We just implemented at UConn an electronic health record, the EPIC, the electronic health record, and that had its own headaches, but we made a strategic decision to make all of our psychiatric notes available. And we had a discussion within the department, and really it was clear that that there were concerns about stigma and what we actually might, the level of detail of what we might put in a note in terms of personal information, but in terms of this is what we're treating, this is the symptoms, this is how we are treating it and making medications available, that was important. So I think that the field, as Dr. Smith noted, we traditionally were siloed, a very psychodynamic approach. What we talk here, nothing to do with, their primary care or anything like that. I think hopefully there are programs and that the field is moving to be much more integrated as well. So with that, I will hopefully brush the chip off and proceed. Nothing to declare. When we talk about cognitive concerns, I'm a geriatric psychiatrist. I live in the world of trying to figure out, is this depression? Is this dementia? Is a little of both? But that's certainly, valid. Also, people with acute medical issues, in the context of a heart attack, COPD flare, sleep apnea, there may be cognitive issues. But I think something that is under-recognized and was just alluded to by Dr. Compton is that there are, within mental illness across the age span, cognitive issues to consider that can affect both functioning and communication. So I appreciate the wonderful feedback I got from both from Lila on shaping this talk, because it's a rather broad kind of notion, and I have 20 minutes, well, I have 17 and a half minutes now because I talked about all my issues. So we boiled it down to what do we mean by cognition? And so thinking about from a neuropsychological standpoint, my colleagues who do the cognitive testing sort of think about different spheres of cognition. And for mental illness, I thought, and particularly for this talk, that I would focus on these. So we'll just dive right in here. Executive function. So executives make all the rules. We know that in our lives. And so the sort of the frontal lobe there is very important for being able to reason, plan, problem solve, being able to multitask, to follow a very complicated recipe where you're doing several things at once. Evaluate the results of actions and decisions, again, prefrontal cortex in particular. Signs and symptoms of what we call executive dysfunction, trouble grasping the main idea of something, trying to weigh benefits and risks, general difficulty making decisions, holding on to a several-step mental process. So, if you're trying to explain, well, this is why we want you to do this because it involves this and this and this and this, pretty soon you're going to see the glazed look, and it's clearly what you're saying is going over somebody's head because they really can't follow multi-steps and hold on to that set in their mind all at the same time. Trouble initiating lists or making new goals. Okay, so this is what I want you to do. Think about, give me all the positives of why you should do this approach. Actually having the mental capacity to generate those lists can be impaired if somebody has executive dysfunction. And flexibility. I'm stuck in a rut. This is all I can do. This is all I can think about. I hear you. You're telling me something new, but my safe zone is continuing on the current path that I'm on. So this is my only brain slide. But basically, executive control. The frontal lobes help govern our thoughts, spoken and unspoken, our emotions, and our behavior. So this is the biggie. The frontal lobe is, there are plenty of studies showing that the frontal lobe is involved in a wide variety of mental illnesses, and I list several of them there. I have learned from the past speaker, I should also include substance abuse. So it says mental disorders and substance abuse, so apologies for leaving that off here, but focusing particularly on these mental illnesses. And of note that this executive impairment can persist even with fairly successful treatment of the other underlying symptoms that people are experiencing. There is something, there can be impairments, slight deficits, weaknesses in executive functioning that can persist, that can affect a wide variety of aspects of people's lives, so that they may have trouble comprehending complex verbal or written communication, trying to figure out one choice versus another, actually making that choice, and as I said, generating a list as well. This paper I thought was very helpful because it sort of helps contextualize when we think about healthcare communication and decision making. So they basically boil down to 4 dimensions: understanding, comprehending the nature and risks and benefits of treatment; appreciation, yeah, I hear you, but how does that apply to me? Reasoning, able to engage in consequential and comparative reasoning, and to sort of figure it out, manipulate that information so that it is useful to them to make decisions; and then expression of a choice. And so each of these aspects can be affected by executive dysfunction. Moving along to memory. This is, again, as a geropsychiatrist, this is a world that I live in, people who may have early stages of dementia, but memory can also memory problems can be present in other disorders. Generally, the brain structures we think about are the hippocampus. This, again, memory refers to ability to take in new information, recall it, hold on to it. Signs and symptoms I include there, hard to hold on to, even so people with severe memory problems. We may have experienced this in our lives, people with maybe an early dementia where they're, didn't you just ask me this 5 minutes ago kind of thing, where really it is a learning deficit. Being able to learn new information and to lay it down, I don't think that people realize that that's sort of the quintessential of what Alzheimer's is. It's a learning deficit, not being able to take in and absorb new information. Difficulty storing information, and difficulty retrieving that information as well. Sometimes we see people with sort of older middle age to older age have early dementing symptoms, but what they are experiencing mainly is depression. So we get a lot of people who present with depression, and when we actually ask about memory, do quick sort of bedside memory type tests, they're not doing so well. Same thing for anxiety as well. Other areas, people with traumatic brain injury, for example, can have memory problems. Memory can affect many aspects of healthcare decision-making and communication, understanding, being able to, you have to be able to retain information to be able to then comprehend it and manipulate it, and then being able to ultimately express a choice. You really have to be, have all the information before you, be able to summon it forth to really then be able to express a choice. Another major area, so executive dysfunction is probably the big area, memory, probably a subset of folks with mental illness, but attention and concentration is another big area. So ability to stay awake and alert, stay focused, and hold on to a train of thought over time. Variety of brain structures, oftentimes what's focused on is the parietal lobe and the frontal lobe. People with attentional problems have trouble staying alert. They don't have enough mental energy to fully engage with people or things in the environment. Difficulty focusing their attention. They can become easily distracted. We see that a fair amount. They can be distracted by things in the environment or internal distractions, thoughts, memories, feelings, worries, voices, things like that can distract them away from being able to attend to what you as a healthcare provider might be trying to tell them. Losing train of thought as well. Can focus, but then quickly lose your train of thought, experience a break in concentration if you're distracted. Sometimes people can't get to the point or may tend to ramble. A variety of mental disorders. For depression, ability to, quote, concentrate, that's actually one of the depressive criteria. Mania, bouncing from people in a manic state, bounce from topic to topic, easily distracted. People with psychosis may have internal distractions, anxiety and PTSD. These preoccupations can really get in the way of focusing on the task at hand. ADD, ADHD, these sort of attentional disorders, as well as traumatic brain injury. So this can affect your ability to understand, ability to reason out, and ultimately to express a choice. So it's important to know when dealing with these with people with these illnesses that all of these factors may come into play, even if a lot of their other symptoms are controlled. They're not actively attending to voices, for example, but they may still have trouble with reasoning, with weighing one decision versus another. And finally, information processing. We see this a lot, and I see this a lot because this is fairly typical for moderate to severe depression. You ask a question, and you could tell the little squirrel is there, but it's sort of slogging through molasses on that little wheel. And if you have enough patience, then eventually you can get that answer out. But it is not at all uncommon to see this sort of the system is slogged. And it can take a long time for people to process that information, which makes it very tricky to actually, in a timely manner, get through what you want to get through, particularly if what you want to get through is leading towards trying to be collaborative in decision making. And so information processing problems are very prevalent in a variety of illnesses. It can be manifested by, as I say here, the slowed thinking, speed and response times. Sometimes then people, because okay, I'm working on this, meanwhile you're sort of out here, they may only get fragments of what you're saying and not being able to pull the whole thing together. And then because it's not only attention to verbal, but also to other social cues, they may not get a sense that you're frustrated with them, that you're really trying to move things along, that you're rolling your eye. Well, God forbid that we would roll our eyes at people, but that these nonverbal cues, they may not be able to attend to those and absorb those as well because they're working on trying to absorb the verbal information and not being able to pick up on some of the nonverbal information and body language of others. And then you're sitting there with somebody and you're wondering, are they even with me here in the conversation? So you can see that again in a variety of illnesses, which I'll get to in a sec. Clearly this slowed speed of processing can impair understanding, as well as reasoning, in terms of being able to sort of get the full picture and then provide a coherent rationale for the decisions that they're making. So with that, I thought I would talk about some examples very briefly. Poor understanding, it is it is very striking to me the number of depressed people that I've seen that really can't summon enough mental energy to be in the moment, in the picture. They're not concentrating well, and you can see it in their facial expression, sometimes particularly in older depression, we call it a Parkinsonian face, sort of lack of spontaneity. And so you can be there and be talking, and they can sort of parrot the words back to you, but it's clear that it's not being absorbed because they're not concentrating very well, and really can't put things in their own words. They're hearing what you're saying, but in terms of being able to process it, because of the sort of lack of mental energy, lack of focus, they may not actually be able to apply what you're saying to themselves. Speaking of which, poor appreciation. Like a manic patient may understand in general what bipolar disorder is, how treatment can help them, but may not have much insight as to why that applies to them. And so we see that in terms of particularly thinking about collaborative healthcare decision-making when dealing with an acutely manic patient. That can sometimes be a very frustrating endeavor, and particularly if there is a sort of a loss of appreciation or loss of insight. Impaired reasoning. A person with schizophrenia, particularly if they've been in the healthcare system a lot, can probably spout back what an antipsychotic is, because they, at some level, they may have been handed a piece of paper talking about that. But in terms of really appreciating why it applies to them, they may decide that they don't want to take a medicine, not because of something that they've been handed about metabolic effects, that it might increase my risk of getting diabetes, but it may be because, well, no, because every time I'm given Zyprexa, I feel like my doctor's trying to poison me. So, that's a different kettle of fish. And knowing that there can be we think about these as sort of psychotic symptoms, but they are closely aligned to sort of this cognitive sphere where your thoughts, your delusions may then affect your ability to reason something out. And then finally, ability to just express a choice. Some people are, particularly when they feel under the gun in a doctor's office, they have anxiety, and then they're in the office and they become very anxious. And it then becomes very difficult and overwhelming to actually go through the process of reasoning something out, making a decision, basically expressing a choice. I can't do it. I can't do it. You decide for me, doctor. That kind of. So it becomes. Again, if the goal is collaborative care, collaborative with the patient, sometimes this can be frustrating for all concerned. But knowing that this is part of the underlying condition that somebody has may actually impair their ability to express a choice, I think is important. It's something that we do try to teach trainees, medical students and residents working with us, but you really do have to be in the trenches and experience this and try to figure out how you're going to equip yourself to deal with having a level of patience, having a level of understanding, and then trying to figure out if there are other ways that you can help the person with better understanding of their healthcare and their healthcare choices. I try to look around real quickly in terms of thinking about ways that one can improve healthcare communication decision-making in the context of mental illness. To some extent, treating the underlying condition can be helpful, but if you're talking about a collaborative model where you're trying to figure out the best treatment, that's sort of like a catch-22. But if you can come to some agreement about the best way to treat, get the anxiety and depression level down, that can be helpful. There have been some studies looking at focusing on cognitive training to help improve executive function and memory. There are games, there are other types of things that have been developed to improve executive function and memory, and then very novel kind of stuff that's coming out that is too early for prime time are things like neurostimulation. So there have been some studies looking at repetitive transcranial magnetic stimulation, for example, to help with some of these underlying cognitive disorders that are part of mental illness. And with that, I thank you for your attention.